here.
I'm not going to try to cover all of vitreomacular interface abnormalities, partly because one of the most important abnormalities is a retinal tear, which has already been covered by Lyndon. So I'm going to talk primarily about macular holes, and then I'm going to go on and talk about submacular hemorrhage. So first of all, macular holes. We all know what a macular hole looks like. It's caused by a combination of antero-posterior traction from the vitreous and centrifugal tangential traction from the ILM. We probably heard of the gas classification, stage 1 hole, where you've got a little bit of elevation of the fovea. I don't know if I can get that to show up there. A little bit of elevation of the fovea. Stage 2 hole, you've got a full thickness defect, but less than 400 microns in diameter. A stage 3 hole, where it's over 400 microns in diameter, and a stage 4 hole, where there is complete separation of the vitreous, but it doesn't matter what the diameter of the hole is. Now, unfortunately, Gass's classification is wrong. It's not terribly helpful in terms of practical outcomes. So it's been replaced by a new classification, the Duca classification, and as I'm going to make clear, that is also wrong. The Duca classification talks about vitreomacular adhesion, where the vitreous is adherent to the macula, but it is not actually distorting the macular anatomy. Then you've got vitreomacular traction, where you've got elevation of the macula, some distortion of the anatomy, and that can lead to a macular hole, and that's subdivided into a small hole, less than 250 microns, that may close with ochriplasmin, a medium-sized hole, 250 to 400 microns, and a large hole, which is over 400 microns. And then again, that's further subdivided into a focal attachment, which is less than 1,500 microns, and a broad attachment, which is more than 1,500 microns. Throughout this, we've been talking about the hole diameter and saying how important that is in terms of staging. And as we'll go on to discover, it's really important in terms of prognosis as well. So how do you measure the hole diameter? Well, it's a little bit confusing because you take the narrowest diameter of the largest section. And here you can see we've got a section that does not go through the diameter of the hole. It's the chord length of the hole. So you want to make sure that the section you've got that you're measuring on is the widest section. So you've really got the diameter. And then you choose the narrowest point of that and measure that. And that gives you what's called the minimum linear diameter, or MLD. And it's not always that easy to measure, and there's quite a bit of inter-observer variation. And so we're looking at other ways of measuring it in the future. Presentation, sometimes a macular hole is an incidental finding. Some patients just may not notice that they've gone blind in one eye. Where they do notice it, it's a loss of central vision. If the vision is better than 6/18, it's very unlikely to be a full-thickness macular hole. The vision is usually worse than that. And if you ask for it, they will always admit to having some distortion and metamorphopsia. It's more common in women than men, about 2.5 to 1. If you've got a hole in one eye, your risk of developing a hole in the other is about 1 in 6 over the lifetime. So it's quite a bilateral condition. And the prevalence is estimated at being about 3 per 1,000 in people over 50, with an incidence of 7 or 8 per 100,000 per year. Now, in order to tell you a little bit more about the prognosis and outcome of macular hole surgery and the things that determine that, we're going to turn to the Beavers Macular Hole Database. And this is a database that includes primary idiopathic macular holes. We've got over 2,300. Right now, it's nearly 2,400 macular holes included, so it's the largest database of macular holes in the world. We've got follow-up data on about 2,000 of them. The primary hole closure rate is very good these days. It's better than 96%. And we're getting 6/12 or better vision in 44%. And the median improvement is 0.42 log Mars, roughly 20 ETDRS letters. Looking at this, we found some interesting things. The holes tend to be smaller in men than women, but this doesn't seem to affect outcome, but it's quite a big difference in the average size or median-sized hole. The onset of the macular hole tends to be earlier in women than men. Women outnumber men, as we said, and they get macular holes a bit sooner or earlier than men do. What are the things that determine anatomical closure? the main thing is the size of the hole. If we look at all macular holes, then the minimum linear diameter, for every micron increase there, the risk of failure increases a little bit. If the ILM peel is not complete, that substantially increases the risk of failure. And waiting time is really important, the interval between diagnosis and surgery. I suspect that's not such a problem in Greece, but it's certainly a problem in the UK. Many of my patients wait 3 or even 4 months between the time they're listed for surgery and actually undergo an operation. But the main predetermining factor is the diameter. And in fact, there's a receiver operating curve shows that this is where Gass and Duca got it wrong, I'm afraid, that we should redefine a large hole not as being 400 microns, but as being 500 microns. Risk of failure, if it's less than 500 microns, is about 1.6%. If it's more than 500 microns, it's nearly 10%. So we should redefine what we think of as a large hole. It also means that a much smaller number of holes are large. If we look at that, we've divided the holes into deciles, so roughly equal numbers represented in each of those bars. And you can see that there's actually very little change between 400 microns and 470 microns. So large holes are not 400 microns. The change comes when you get to over 500 microns, and that is clearly a large hole. I said that waiting time is an issue. It may not be an issue so much in Greece, but it's certainly an issue in the UK, that the longer you wait, the more likely the hole is to fail. The median waiting time for closed holes is 4 weeks, but for open holes it was 8 weeks, and this is a significant difference. Now, that probably doesn't make a lot of difference in small holes. So if you've got a hole that's 350 microns or even 400 microns, the waiting time may not matter so much. But if you've got a big hole, then the sooner you operate, the better. The visual outcomes, again, are predicted primarily by the size of the hole, the minimum linear diameter, also the preoperative vision, and the duration of the patient's symptoms, and whether or not they have pre-existing macular degeneration. If they've already got a damaged RPE, then closing the macula over that doesn't necessarily improve the vision as much as we would want. In contrast to the anatomical success rate, where the graph was fairly flat and then shoots up at 500, when you look at visual outcome, it's a much more steady trend, with the visual outcome worsening for every micron increase in diameter. The duration of symptoms matters here, that patients that have got a short duration of symptoms, less than 4 months, do much better than those that have got a longer duration of symptoms. This data is somewhat flawed because about half the patients you really can't be sure how long they've had the symptoms. But it does seem that early referral and early treatment does help. We've recently completed the PIMS trial that's been submitted for publication, and we hope will be in print fairly soon. 180 macular holes, and these were large holes of over 400 microns, were randomized either to be postured for face down 8 hours a day or to sit still, sitting face forward for 8 hours a day. And the closure rate was slightly higher in those that were postured than those that were not, but the trial wasn't powered to detect such a small difference, and so it was not significant. However, when you looked at the mean final vision, that was significantly better in the face down group than the face forward group. And so, although the anatomical effect is not proven, I still posture all of my macular holes face down for about 24 hours because of the improved visual acuity results. Now, there are some problems with this. We should remember this was not face down versus no posture. It was face down versus sitting still. And secondly, we didn't attempt to measure the adherence to posturing. All we could test was the advice to posture. Now, that's full-thickness macular holes. We also have lamellar macular holes, and there's been some interesting developments in that. Recently, I think we have a better understanding of them now. We recognize 2 distinct types: the degenerative macular hole, also known as the top hat type macular hole, because of the shape on the OCT, and the tractional macular hole resembles a sort of ringmaster's moustache with a big moustache. An international working group was convened to look at these and to see if they could identify the diagnostic criteria for these different types of lamellar hole. They're not just one type of lamellar hole, there are different types. And they identified 3 types: the lamellar macular hole, what they call an epiretinal membrane fovea schisis, and the macular pseudohole. A lamellar macular hole has got to have the mandatory criteria, which are an irregular foveal contour, foveal cavitation, and loss of foveal tissue, sometimes accompanied by a pseudooperculum. And then the minor criteria, you get this lamellar hole-associated epiretinal proliferation, sort of grayish membrane on the surface, a little bump at the fovea, and loss of the ellipsoid zone as well. So that's the classic degenerative lamellar hole. We should reserve the term lamellar hole for that type of hole. Then you have the epiretinal membrane fovea schisis, which has sometimes been called a tractional hole in the past, or macular pseudohole with stretched edges. The mandatory criteria here are the contractile epiretinal membrane, a schisis at the level of Henle's layer in the retina. Minor criteria include cystoid spaces. There's some thickening of the retina there, and also some retinal wrinkling can be seen on the en face view on the OCT. And finally, you have the macular pseudohole, where you can see an epiretinal membrane, which doesn't go over the fovea. There's thickening of the retina, and you've got a very vertical profile to the foveal pit. Minor criteria would be the microcystoid spaces and almost normal central foveal thickness. The prognosis of lamellar macular holes is that the anatomical appearance tends to worsen. You get progressive loss of the perifoveal tissue, but there seems to be very little change in the visual acuity. You can see here some scans repeated over years. There's progressive loss of tissue, but the vision really doesn't change very much from 2020 to 2025. And so there is as yet no evidence of any benefit for any surgical or any other intervention. These patients do not need referral, and they do not need treatment at this stage. Quickly, just a little bit about epiretinal membrane. These are very common in older people. The Blue Mountain Eye study found that if you looked at people over 70, 1 in 10 had an epiretinal membrane. The Victoria Visual Impairment Project showed 15% of people over 70 had an epiretinal membrane. So these are very, very common. The vast majority of patients do not have symptoms and do not need any treatment. It's caused by a glial tissue on the surface of the retina that contracts and causes distortion of the retina and distortion of the anatomy. And that, in turn, leads to distortion of vision with metamorphopsia and sometimes reduced visual acuity. You can see a sheen, a slight shiny appearance on the surface of the macula with some retinal folds and some distortion of the blood vessels. They may be straightened, or elsewhere they may be increasingly tortuous and wrinkled, and you may see a visible membrane. This is a fairly subtle membrane with this straightening of the blood vessels and a slightly shiny appearance on the surface. Here's a much more obvious membrane, which is clearly visible. Causes of epiretinal membrane include posterior vitreous separation, where the vitreous comes away from the retina, and that is thought to cause some damage to the ILM that allows glial proliferation on the surface of the retina. If you've got any retinal breaks, then shedding of the RPE lends up on the fovea, and you get metaplasia of the pigment epithelial cells and formation of an epiretinal membrane. Other things such as a retinal vein occlusion or diabetes can also be associated with epiretinal membrane formation. Crucial point here is the management is you really don't need to do anything unless the patient is symptomatic. The question I always ask people is, do you close your bad eye in order to see better with the good eye? If the epiretinal membrane is sufficiently symptomatic to interfere with the vision in the good eye, it's probably worth considering treatment. If it isn't, then they don't need treatment and they don't need referral. We are, in the UK, inundated by referrals of asymptomatic epiretinal membranes that are being detected on OCT by optometrists, and they're all being referred in, and it's really not necessary. Unless the patient has symptoms, nothing is needed, because these do not progress. In the vast majority of cases, epiretinal membranes are static. If you do operate, then you do a vitrectomy and membrane peel with or without cataract surgery at the same time, and about 80% of patients will report their symptoms are improved. Finally, just very briefly, vitreomacular traction. Again, OCT has allowed us to diagnose this in many, many more patients. Again, as with epiretinal membrane, the vast majority of people with vitreomacular traction are asymptomatic, and they do not need treatment. A very few patients, it will progress to a full-thickness macular hole, in which case we can treat that with a 96.5% success rate. So there's no point in treating all the vitreomacular traction in order to prevent a few macular holes. It's better to treat the macular hole if it occurs. If they do have symptoms, then there are two possibilities. You can do a vitrectomy and peel the vitreous, and that will relieve the traction, but it's quite a big invasive procedure. Another possibility is to inject a very small bubble of C3F8, and as that expands, it separates the vitreous from the retina. But as yet, there are no randomized controlled trials to assess the management. Once again, the vast majority of patients who have vitreomacular traction don't need anything doing. I'd just like to leave you with 3 points. Firstly, remember that large macular holes are 500 microns or greater, not 400 microns or greater. Secondly, that urgent referral and urgent treatment does improve the outcomes. And finally, remember that not all lamellar holes are genuinely lamellar holes. The lamellar hole should be reserved for the true degenerative type lamellar hole. Have I time to move on with the next one, or do you want to go straight on with the debate? Okay, so if I could have the next presentation, please.
Just one little question. Would you treat the epiretinal membrane-related lamellar hole, which is the vitreoschisis, as an epiretinal membrane? If you usually follow criteria, because you classify them as different entities.
So if somebody's got a Suber hole or an epiretinal membrane tractional, then I would assess them on the same way as I would assess an epiretinal membrane. Are they symptomatic because of the epiretinal membrane? And I would then address that. But those are not lamellar holes. Okay. So I want to quickly go over some of the options and outcomes for the management of subretinal hemorrhage. Subretinal hemorrhage occur in different places. If it's away from the fovea, you can safely ignore it. But if it's under the fovea, it's seriously bad news. The blood damages the photoreceptors as you get contraction of the clot. There's the toxicity of the iron, the hemosiderin within the blood, and you've got a disruption of the metabolic support from the RPE. So blood under the fovea causes profound visual loss very rapidly. Number of different causes for it. The 3 most common causes are trauma due to choroidal rupture. It's easy to recognize that the patient has a history of severe blunt trauma. You may have a macroaneurysm. The key thing there is on OCT, you see sub-ILM hemorrhage. If there is hemorrhage under the ILM, then that is almost certainly due to a retinal macroaneurysm. And finally, there's neovascular AMD causing submacular hemorrhage, and usually associated with a pigment epithelial detachment. Now, the first 2 causes, the prognosis is fairly benign. There's not much evidence that surgery improves it, and I tend to just observe those. However, if you've got a submacular hemorrhage due to AMD, they do very badly, and it's, I think, usually worth intervening. Sylvia Bopp produced a nice classification of the different types of hemorrhage based on the size of the hemorrhage primarily. You may get a tiny little hemorrhage, which Adnan showed earlier today, very common in RAP. You may get a sort of circular hemorrhage around the classical type of CNV. You may get a small hemorrhage, less than 2 disc areas, or a big hemorrhage, which is 2 disc areas or more, or really massive hemorrhage that goes out to the arcade. And it's these last 2, 4 and 5, that are ones that are most likely to benefit from surgery. And they're actually quite a small proportion. Again, this is from Sylvia Bopp's paper. Just over 6% of eyes with AMD have these kind of large hemorrhages. So it's not very common. The treatment for these, you may use anti-VEGF alone, and the CAT study looked at predominantly hemorrhagic lesions compared to those without hemorrhage, but there were turning to be fairly small hemorrhages. There were less than 5 disc areas, so quite small, and the mean visual acuity beforehand was 56 letters. Now, that's pretty good. Most of the hemorrhages that I'm talking about, the vision is counting fingers. So I'm not sure that you can apply this to large hemorrhages. These were basically small hemorrhages. What about the bigger hemorrhages? These tend to have, 696 vision or worse, in which case in the UK they wouldn't be eligible for anti-VEGF treatment. There's blood actually under the fovea, not just near the fovea, and they're often more than 15 square millimeters in area with more than 500 microns of thickness. These are bigger hemorrhages, and your options there are either intravitreal gas with TPA to displace the hemorrhage, or a vitrectomy and subretinal TPA in order to move the hemorrhage even more. Intravitreal gas, you have to put in 0.3 ml of C3F8 and 50 micrograms of TPA. It's quite a lot of volume to put into the eye. You'd need to do an AC paracentesis before and again afterwards. Initially, you mobilize the patient, and then by the evening, when the gas is expanded a bit overnight, you have strict face-down posturing. And the results of that are quite good. The alternative, rather more invasive, is you do a vitrectomy and you inject subretinal TPA with or without an anti-VEGF in the same mixture, and then put a gas bubble in, leave them supine for a while so that the TPA liquefies the blood clot under the retina, and then sit them up and lean forward. And the results of that, again, are pretty good, over 3/4 of the patients gaining 2 lines at 12 months. But comparisons of the techniques are very difficult. There are a large number of published case series, but the entry criteria vary, the outcomes are very different, the interventions are often subtly different in every paper. So what are the things that do influence the outcome? The size of the hemorrhage is probably the most important thing, both the thickness and the area. And the duration is important as well. The sooner these are treated, the better the outcome. The initial visual acuity reflects the ability of the photoreceptors to recover, and the underlying pathology is important as well. We've already said that macroaneurysm tend to be fairly benign, the hemorrhage there anyway. Other possible things that might affect the prognosis are the pigment epithelial detachment, and last of all, the type of procedure that you do to displace the hemorrhage. And I think that actually doesn't matter very much. The other things matter far more. So let's look at those risk factors. The hemorrhage area, this is from data we produced from Glasgow. You see with increasing hemorrhage area, the mean visual acuity declines. The duration is important. Shorter duration, you get better mean visual acuity. And the presenting visual acuity is important as well. If you're down to hand motions or PL, that reflects profound damage to the macula, and it's harder to come back from that. The single most valuable predictive factor was the area of the hemorrhage. And Julio Gonzalez showed in this rock curve, the area under the curve is nearly 80%. And that if the area of the hemorrhage is more than 30 square millimeters, that has a 90% sensitivity and 73% specificity for predicting final vision of 660 or better. A small series from the UK where they were able to treat patients very early using intravitreal gas, and they found that although intravitreal gas may not displace the hemorrhage as effectively as subretinal TPA, because they were doing it very promptly, they're getting onto these patients very quickly, they got remarkably good results. So it's important that in dealing with this, you minimize any delay in treatment. You need to have a good pathway from the AMD clinic to the VR surgeon so that the treatment can be delivered. And in Glasgow, we're fortunate to have that. The whole region around Glasgow knows what to do with these patients, and we usually aim to see them in the clinic either the same day or the next day and operate the following day. Does pigment epithelial detachment matter? The short answer to that is no. Virtually all of these patients do have a pigment epithelial detachment, and virtually all of them have hemorrhage under the RPE. And it doesn't seem to make much difference whether it's primarily subretinal hemorrhage or primarily sub-RPE hemorrhage. RPE rip does occur in a number of these patients, but it also occurs in patients that are having anti-VEGF treatment in the presence of a PED, and the incidence is not that dissimilar. So which procedure is better? Should we give subretinal TPA, which Joost Hillenkamp and his co-workers showed was better than intravitreal gas, or should we give intravitreal gas, which Jan van Meurs showed was just as good as subretinal TPA? So you may all be feeling a little bit confused and wondering, like this chap, where do I go from here? But I think there are some conclusions that we can draw, some simple things that we can agree on. Firstly, you need to organize a referral pathway. If you are treating patients with AMD, then you need to know, what do I do if somebody comes in with a big hemorrhage? You need to have a VR surgeon that you can go to and say, can you manage this for me? If the vision is 660 or better, particularly if it's better than 60 and it's a small hemorrhage, then I think the evidence is that it's perfectly reasonable to treat that with anti-VEGF alone. It's the big hemorrhages that need more aggressive management. I think it's widely agreed that if you've got a very large hemorrhage, the outcomes are worse, and we should aim to treat immediately, really as soon as possible, in order to get the best possible outcome. And once the hemorrhage has been there for a couple of weeks, there's really very little that anybody can do about it. By that time, the clot is organized, and you've got severe damage to the overlying retina. There's some evidence that vitrectomy and subretinal TPA is more effective at displacing the blood, but the intravitreal gas works very well. And if you're in a situation where you can give the intravitreal gas immediately, but you have to wait until next week before you can have a vitrectomy, then you're probably better off giving the intravitreal gas. And of course, you then need to maintain the anti-VEGF after that. If anybody is involved in treating these patients, I would encourage you to try to standardize the reporting a little bit so that you measure the size of the hemorrhage and report the visual outcomes clearly as well. There's going to be a randomized controlled trial, which funded by Euretina. We've got €2 million for that, and that should be starting within the next year or so. And if you want to read any more about this, there's a very good review article in Survey of Ophthalmology. The reference is up there. Thank you very much.
Thank you very much. Excellent. Any questions on those subjects? Shall we move on to the debate now?